Guys, this is Mobeen. We are talking about pulmonology. The lecture today is the regulation of respiration or control of breathing. In this lecture today, we'll discuss about how is the quiet breathing controlled, how is forced breathing controlled, how is conscious breathing controlled, for example, how is that breathing controlled. We'll talk about the chemical receptors that help in controlling the breathing. We'll talk about the neuronal controls of the breathing, and we'll see the other factors that affect these breathing rates and the depth. So two things we have to talk about: the rate of breathing, fast rate or slow rate, and then depth, shallow breathing versus deep breathing. So all of these things should become clear as we study today. So the way we'll study is, first of all, let's make diaphragm. So of course the diaphragm is the receptor, is the muscle, not the receptor, of the quiet breathing. On the diaphragm, I'm going to put a heart here. And in this heart, what we are really interested in is mostly the arch of aorta. So in the arch of aorta, we have, this is the brachiocephalic trunk, and this gives off common carotid on the right side. On the left side, common carotid is a direct branch of the arch of aorta. Common carotid. The common carotids then bifurcate into internal and external carotids, right? So at the bifurcation, we have carotid sinus and carotid body. So we have a dilatation here and we have a dilatation here. That is the carotid sinus and carotid body. We are more interested in carotid body today. Similarly, aorta has some receptors above and below in it, which are called aortic bodies. Now, these are chemical receptors. These are also called peripheral receptors for breathing. We'll make them useful in a few minutes. I want to continue going up and look at what we have. This is the pons and this is medulla. So this is the anterior surface, this is posterior surface. Okay, so the way the lecture will be structured is this, that on this side we'll talk about inputs, the factors that influence the breathing, and on this side we'll talk about outputs, that is the how, when an efferent impulse comes in, how does the system send the efferent and what happens. Now first of all, let's look at the quiet breathing and how that works. We're not looking at the receptors yet. So in the dorsal medulla, the nucleus of tractus solitarius, NTS, is the dorsal respiratory group of neurons which control, primarily these are the neurons that control quiet breathing, and they control the breathing rhythm as well. So these neurons in the medulla are responsible for the breathing rhythm and quiet breathing pattern. Guyton says, the Guyton book says, that if you sever this neuronal set from above, from the influences above, there are more neurons and more nuclei above, even then the respiratory rhythm continues for the quiet breathing. So keep that in mind. Now what happens is, this dorsal respiratory group, or called DRG, dorsal respiratory group, is connected So before we talk about connection, if you sever all the connections to it, it has its own pacemaker and it has automaticity. What is that automaticity? We know that normal quiet breathing rate is about 12 breaths per minute. About 12 breaths per minute, which means about 5 seconds per breath. So this dorsal respiratory group creates something that we say respiratory ramp. Respiratory ramp. What that is it starts for 2 seconds, it starts inspiration. It sends the signals to the diaphragm, quiet breathing, diaphragm for the inspiration. Then it cuts off that signal and for 3 seconds it is quiet. So what it does is it does this. There is a ramp, goes up for 2 seconds and then for 3 seconds comes down. This is the ramp breathing signal. So once again after 3 seconds it goes up again for 2 seconds and then comes down again for 3 seconds. So 2 seconds, 3 seconds. This is one complete breath. 2 seconds, 3 seconds, one complete breath. So that is how the nucleus of tractus solitarius or the dorsal respiratory group. Now this group is also present. There are surrounding reticular formation fibers that are present here as well, that are also taking part in the breathing, quiet breathing. So now let's connect this system. How will it send the order to the diaphragm for the breathing? Well, simple. The nerves from here go to the diaphragm and supply this. Which nerves are these? I hope you know. These are the phrenic nerves. Phrenic nerve. And we know that phrenic nerve comes out at the level of C3, 4 and 5. Right? So we know that phrenic nerve comes out at the level of C3, 4 and 5. That means if there is a severance of the spinal cord at the level C2 and above, then this phrenic nerve will be cut down, and so the quiet breathing rhythm for the diaphragm, the automaticity of the diaphragm for the quiet breathing will be gone. So the breathing is in trouble. Automatic breathing, unconscious breathing is in trouble, involuntary breathing, if C2 level and above has been rejected. If we have C6 and lower, if we have C6 and lower lesion in the spinal cord, then that does not affect the breathing system because phrenic nerves are intact. However, any damage to C3, 4, 5 can also affect the breathing. It depends what is the damage to the phrenic nerve and how extensive and if it is bilateral or not. Okay, so keep that in mind now. So phrenic nerve is the output. As told you that on this side we'll talk about the output. So this output is going to the diaphragm. Diaphragm. There are some fibers that also go to the, if this is a rib, this is another rib. So then we have external intercostals. So there is some output to the external intercostal as well, but primarily the diaphragm. Diaphragm is the muscle of quiet breathing. So that is input. Now, can this system by itself work and keep us breathing? Yes, it can. Should we modify this system to change the breathing rate as the conditions in the body change? Yes. So remember one thing, that all the conditions in the body that would change the rhythm, depth or the rhythm or the frequency, these are going to affect these nuclei. So let's see the first one. First one is from the carotid body, glossopharyngeal nerve relays here. So nerve number 9, glossopharyngeal nerve, that goes from the carotid bodies and relays in the nucleus of tractus solitarius or the dorsal respiratory group. What is the effect of this one? this carotid body, I'm going to write the, so carotid body here, carotid body is sensitive to pressure of oxygen. Now keep this in mind, both carotid body and the aortic bodies are sensitive to the dissolved oxygen. They are not sensitive, they cannot measure oxygen on the hemoglobin. So they cannot look at the oxygen content, they cannot look at the saturated oxygen on the hemoglobin. They can only look at the pressure of oxygen in the dissolved plasma. Keep that in mind. So you may have, for example, in carbon monoxide, you may have carbon monoxide sitting on the hemoglobin, but the dissolved oxygen in the plasma is okay. So these guys say, well, everything is fine. Why? Because they do not look at the oxygen on the hemoglobin, they don't look at that. Okay. So PO2 is measured by the carotid body and the aortic body. This aortic body sends the impulses up through which nerve is this? Nerve number 10, vagus nerve. For vagus nerve and for glossopharyngeal nerve, for both of them, the sensory relay is nucleus of tractus solitarius or dorsal respiratory group. Now, please keep this in mind, write it down somewhere. During the quiet breathing, the effect of peripheral chemoreceptors, which sense pressure of oxygen, is very little. It is negligible, meaning if you cut it down, breathing rate would change a little bit, maybe from 12 it will come down to 10, but not a significant effect during quiet breathing. But when we are exercising or when the breathing has become increased for other reasons, that is when these things will start taking part. But please now write it down as well. Carotid body and aortic body, they both are sensitive to the pressure of oxygen, dissolved oxygen, and they only affect respiration when oxygen pressure drops significantly. How significantly? Until the oxygen pressure PO2 drops below 60 millimeter of mercury, they do not work. They do not work a lot. So if I make a little graph over here, I'll say it this way, that if this was 100, remember 100 is the normal oxygen pressure in the arteries, PaO2 is 100. So when it drops up till 20, so let's say this is 40 and this is 20 and this is something else, oxygen, and let's say this is the respiratory rate. So this is 12 breaths per minute or 1x respiration, 1 times, this is 2 times, this is 3 times. When the pressure of oxygen drops to 20, that is when the peripheral chemoreceptors trigger the dorsal respiratory group and bring the respiration to 3 times the rate. So instead of 12, it would become 36 or 30. However, till we reach 60, till we drop 60, there is actually no change. So from 100 to 60, pressure is dropping, but there is not much change. So that is the quality of the peripheral chemoreceptors. How would you summarize that in your mind? You would summarize it that normally for quiet breathing, they do not do much. A dramatic decrease in oxygen is when they become active. Cool? Okay. Now let's continue discussion here. There are other triggers that affect this as well. So let's make a bronchus here. Remember the bronchus, there would be lungs and bronchi here, so I'm going to move that a little away. So let's make some airway, and let's say this is an alveolus. This is lung tissue. Then let's also make a muscle spindle sitting in a muscle. So this is a muscle spindle. This is a lung. So now 3 more triggers for the nucleus of tractus solitarius. One is muscle spindles can send positive signal for increasing the respiratory rate. And what is that? Actually, Golgi tendon organs and muscle spindles both. For example, if I start doing exercises right now, as I start doing exercises, my muscles and my joints will send messages through the muscle spindles and the Golgi tendon organs to the higher centers. These messages also go to the dorsal respiratory group and they trigger it to increase the breathing. So in the early parts of the exercise, the increased rate of breathing is triggered by the muscle spindles and the Golgi tendon organs. Then in the bronchi, in the airways, there are irritation receptors. There are receptors present interspersed in the epithelium. These receptors are called irritation receptors or irritant receptors. Irritant receptors. These receptors look at the obnoxious gases, pollen, dust, any such thing that would trigger them, and when they are triggered, they invoke a cough reflex or they invoke deeper and higher frequency breathing. So that is another type of receptor that does this. Then in the bronchial walls, the smooth muscles here, the smooth muscles in the walls of the bronchi, these smooth muscles also have the muscle spindles there, right? So the stretch of these smooth muscles, overstretching, if I do this, overstretching of these smooth muscles will also send, what do you think they should send, what kind of an influence they should have? Negative influence. The deeper breathing will cause the respiratory rate to become slower. So stretch receptors from the bronchial or airway smooth muscles send negative or suppressive signals to the nucleus of tractus solitarius or dorsal respiratory group and reduce the respiration rate. How about alveolus? I made that over here as well. Alveoli have gotten a thing that is called J receptors in them. They have gotten J receptors. These J receptors are interspersed in the pneumocytes. They are called J receptors because they are juxtaposed to the capillaries. So here are some capillaries and these J receptors are nearby. These J receptors are triggered when there is fluid present. So when is the fluid present in the lungs? Let's use one most common is the congestive heart failure. When there is heart failure, congestive heart failure, there is back pressure and the fluids, edema occurs in the lungs. That edematous fluid triggers the J receptors and J receptors then in turn send positive influence to the nucleus of tractus solitarius or the dorsal respiratory group and they increase the breathing. So breathing becomes shallow and high frequency like that. Now remember this stretch receptor or this stretch reflex is also called Herring-Brewer, these were the two scientists, Brewer reflex as well. Okay, so now what we have seen is from the periphery there are things either chemical or non-chemical that are influencing the nucleus of tractus solitarius to increase or decrease the rate of respiration, not the depth of respiration. My dear student, let me hug you and tell you this again, not the depth of respiration. Why? Depth of respiration will be controlled by a different nucleus. So let's talk about that. I hope quiet breathing is clear and the factors affecting it is clear. Let's look at the nucleus present here in the ventral part of the medulla. This is called, of course, the ventral respiratory group or VRG, ventral respiratory group of neurons. This particular one I'm going to draw in green. It sends outputs to, number one, it excites the NTS, and NTS excites this. Normally, the excitation of the ventral respiratory group is in the hands of the dorsal respiratory group. When dorsal respiratory group is influenced too much, when it is triggered too much, when there is lots of excitation over there, that spills up and out and triggers the ventral respiratory group. So the automaticity of the ventral respiratory group is under the control of dorsal respiratory group. So it works with that. So if dorsal is inspiring, then the ventral is also inspiring. If dorsal is expiring, then the ventral is also expiring. However, ventral respiratory group sends impulses to extra muscles of breathing. For example, internal intercostals and the other muscles that take part, abdominal muscles and so on, that take part in forced respiration. So this area is for the forced respiration. And how and when does it become active? When the nerve impulses spill over from the dorsal respiratory group to the ventral respiratory group. So now we know that if there is too much, for example, let's say stretch reflex comes in, and if it is too much of the signal here, then the dorsal respiratory group would also become active. Alright, so we got these two. Now let's talk about another thing. I'm going to erase this here and put it here. Ventral respiratory group, because I want to draw something here. So what I'm going to draw here is effect of carbon dioxide. This is an input system. Instead of developing it here, because we have already gotten the space gone, I'm going to draw it here. So what happens is, let's say this is a blood vessel. This blood vessel has carbon dioxide in it, and of course it has hydrogen ions in it. The carbon dioxide is the primary trigger. Please write it down somewhere. Carbon dioxide is a primary trigger of respiration, quiet respiration. So what happens is, carbon dioxide is lipid soluble. It crosses the blood-brain barrier. This is the blood-brain barrier. It crosses the blood-brain barrier easily because it is lipid soluble. However, hydrogen ions cannot cross the blood-brain barrier, so they stay outside. They cannot cross. Carbon dioxide that comes in, you know what it would do. Carbon dioxide will combine with water to give H2CO3, which will then give hydrogen and bicarb. This hydrogen ion affects the ventrolateral surface of the medulla. This ventrolateral surface of medulla is called the central chemoreceptor. Why central? Because it is in the brain. Chemoreceptor, because it's going to look at the hydrogen. When it is looking at the hydrogen, what is it sensing? It is sensing the pH of the CSF. This hydrogen ion is now present in the CSF. We have CSF all around here, right? So CSF pH is controlled by the carbon dioxide from outside. If carbon dioxide is more, for example, if I start hypoventilating, hypoventilation would increase carbon dioxide. If I stop my breathing, carbon dioxide levels are increasing. That would increase carbon dioxide in the CSF from the blood. That would cause more hydrogen ions to be produced, increase pH. That pH affects the ventrolateral surface of the medulla. There are sensors there, and what would they do? It's an input system, so they would work on the nucleus of tractus solitarius or dorsal respiratory group, and they would excite it, and that would mean increased respiratory rhythm. However, if it becomes too much stimulated, then the ventral respiratory group will also become involved, and that would mean deeper respiration, right? So that is the effect of the carbon dioxide. Now remember this, the acidity of the blood does not have effect on the central chemoreceptors. Why? Because hydrogen ions cannot cross the blood-brain barrier. What does that mean? That means if I start doing exercises right now and I produce lactic acid, that lactic acid and the hydrogen ions produced, they are not going to have any effect. That is why exercise does not have effect on the chemoreceptors of the center. However, with the exercise, I produce more carbon dioxide. That carbon dioxide will dissolve in, create more hydrogen ions, which would then decrease the pH, and that would cause the effect as well. So keep this in mind. This is a USMLE question. So now, normal quiet breathing, carbon dioxide has an effect. So we say that quiet breathing is triggered and controlled by carbon dioxide levels. However, the forced breathing can also be because of oxygen. So let's look at the carbon dioxide graph over here. Compare that to the PO2 graph. Carbon dioxide, we know that normally it is at 40 millimeter of mercury, PCO2 rather. When it goes from 40 to 60, only 20 more, it causes breathing rate to go up to 4 times. 4 times. This is the effect. Carbon dioxide, just 20 more pressure units and the breathing rate goes up to 4 times of normal breathing. However, you saw that the oxygen continues to drop, and at 20, from 100 to 20 is when it goes to 3 times. From 100 to 60, not much, nothing, no action. So please remember this, that carbon dioxide has a higher influence than PO2 in normal situations. When the PO2 dramatically reduces, then the body's respiration becomes PO2 controlled. Okay, now let's go up. What you would see is that in the neuronal system, as we continue to go up, we'll go from automatic to conscious activity. Above there in the medulla, in the pons, this is pons, this was medulla. In the pons, we have 2 more respiratory centers. One center is called apneustic center. Apneustic center. Apneustic center is in the caudal pons. And what does apneusis mean? Apneusis means deep breath, deep gasp. That is apneusis. What do you think? Is it a forced breathing or not? Yes, it is a forced breathing. What do you think? Does it need the ventral respiratory group to become active? Yes, it does, because we need extra respiratory muscles to be active as well. So apneustic center directly does not control anything. It controls the dorsal respiratory group, and it sends so many signals there that the signals spill over and the ventral respiratory group becomes active as well. That pattern is always going to be the same. You basically influence the dorsal respiratory group, and if the influence is too high, then that can involve the ventral respiratory group, and that would cause the extra respiratory muscles to become, extra muscles of inspiration and expiration to become active as well. Now, so that is the apneustic center. What does that mean? Whenever we want to have a deeper, longer inspiration, apneustic center is the one that switches on the inspiratory system and says, no, you're not going to stop in 5 seconds. Instead, I want you to continue inspiring for 10 seconds. Apneustic center. Okay. Now, how does the pneumotaxic center work? This is pneumotaxic. Pneumo means breathing air, taxic means movement. Pneumotaxic center is the center in the rostral pons, and that inhibits apneustic center. So if I want to have rapid shallow breathings, this is happening with the pneumotaxic center. Pneumotaxic center cuts off. It can actually reduce an inspiration to 0.5 of a second, half a second. Normal inspiration 5 seconds. 5 seconds normal. The pneumotaxic center, when it inhibits the system below, it can cause the inspiration to only occur within half a second. How many half seconds in 1 minute? 1 minute has 60 seconds. Half seconds will mean 120 seconds, 120. So it can create a rhythm of 120 breaths per minute. although you know that the carbon dioxide will be washed out and then carbon dioxide would have its effect and it would try to suppress it. But that is a function of the pneumotaxic center. It increases the rate of respiration. Apneustic center increases the depth of respiration. Now this is it, we've gotten this. Now is there something more? Yes. Can we consciously control breathing? Yes, I can. That is conscious breathing. Can the conscious breathing be overridden by this system? Yes. If I hold my breath, PCO2 is increasing, and as it increases to a particular level that body cannot tolerate, then these centers are going to override my conscious activity and break it, and they'll ask me to breathe. So how can, when you are having a match of who can hold breath for longer, how can you win that? There's a very simple thing. Do a lots of rapid breaths before and wash out your carbon dioxide. Wash it out, then do a deep breath. Now carbon dioxide would come up very slowly because you have washed it out more than normal, and you can hold your breath for a longer time. Tell me when you win that competition. So higher center, limbic system and our higher motor areas can influence these areas below, and they can also cause deeper and faster breathing or slower breathing. Conscious breathing can happen with that. Okay, so a couple of important things. One is the anemia. Some students have asked me, why do we not have increased breathing in anemia? So normally in anemia, the PO2, pressure of oxygen inside the dissolved oxygen pressure, is not changed. It is the saturation of the hemoglobin that is changed. And our chemoreceptors, the peripheral chemoreceptors, do not care for that. So due to that, in anemia, normally breathing does not change too much. However, if the hypoxia or hypoxemia becomes too much that the tissues start complaining about it, then we may see increased breathing. So this is the lecture today. Thank you very much.